Hi, I am Doug Cox, a pastor and the executive director of Global Health Ministries, here with Dr. Magdalene Agard, also from our staff, the director of consulting for Global Health Ministries. And we have the privilege tonight to introduce a special guest. It is a great honor. And I would like to just say a few words to introduce Dr. Michael Osterholm, who is certainly a world-renowned epidemiologist. He actually served on President Joe Biden's COVID-19 Transition Advisory Board, which might make you aware of him no matter where you might be, and has been Minnesota's state epidemiologist for 15 years, I believe. And during the height of COVID-19 pandemic, people all around the world were able to rely on his ability to distill complex things into very helpful and understandable communication. Dr. Osterholm holds one of the highest honors for faculty at the University of Minnesota as the Regents Professor McKnight Presidential Endowed Chair in Public Health. And he directs the Center for Infectious Disease Research and Policy, serves as a professor in really multiple institutes and colleges in the University of Minnesota. I could go on, but I want to just say one more thing. I want to mention that Dr. Osterholm has been an international leader on concerns such as preparedness for an influenza pandemic. He's a frequent consultant for the World Health Organization, the National Institute of Health, the Food and Drug Administration, the Department of Defense, and the CDC. Many ears listen to Dr. Osterholm as we get to tonight. And finally, Dr. Osterholm is also a Lutheran. So he's a member of Edina Community Lutheran Church right here in Minnesota. And so I just want to say as warm a welcome as I possibly can, Dr. Osterholm. It is an honor to meet with you today and to allow our partners and friends of Global Health Ministries around the nation and the globe to hear your words and to learn together. So
Thank you.
welcome.
Thank you very much. It's an honor to be with you. Thank you.
Thank you. Thank you. I'm going to start us out with a quick question that I think is too easy, but maybe still something that we all need to learn, and you could teach us, I'm sure. It would be helpful for our audience to understand, what does global health actually mean?
Well, when you're talking about the world of infectious diseases, global health means that anywhere you are in the world may be of a problem that tomorrow will be somewhere else in the world. A germ that is halfway around the world today can be around the world by the end of the week. And so really, when you think about taking care of our health here in this country or any other high income country, you have to understand that that health can surely be compromised by the very worst of what can happen in low and middle income countries. And of course, that doesn't mean that it doesn't also happen in high income countries too. So the point of it is, we all are each other's brother and sister when it comes to infectious diseases. And we have to understand how critical that is in terms of then what we do, what we think about, in terms of how we talk about these diseases, and understanding their impact.
Great. Now, thank you for making it easy to understand. I'm going to ask you a faith question, if I may, about global health. Really, it's a simple question, but the answer might not be as easy. But it's just, why do you think Christians, particularly, should care about global health?
Well, first of all, let me be really clear. I think everyone should care. And I'm willing to work with and support whoever you are, whatever religion you may come from, whatever your party politics might be, whatever. We should all be concerned. But when you think about the Christian faith, of course, and we think about what it is that grounds that Christian faith, taking care of our brothers and our sisters is at the very heart of that. And so to understand what this means from a science standpoint, we surely can get into the details of drug treatments and vaccines and all that. But when it gets into the point of personal motivation, I think that that is one where it should apply across the board. And Christians, like hopefully all other religions, will be at the forefront of wanting to take care of each other.
Thank you so much. Dr. Osterholm, I've heard you speak about the recent government cuts in funding and layoffs with the memorable phrase, "We cannot give up or give in." Would you unpack some of what is at stake? In particular, what do you believe might be the impact on people or individuals who are facing public health cuts globally?
Well, first of all, Magdalene, let me just say that I have had the wonderful opportunity to spend 50 years in the public health world. And in those 50 years, I have always been what I would call a supporter of whoever I was working for, meaning that much as someone who's in an army or in some kind of a team, I'm there to support them. I worked for 2 Republican governors and 2 Democratic governors, and I say affectionately one independent wrestler here in Minnesota as governor. I've had a role in every presidential administration dating back to Ronald Reagan, where I served early on in the HIV/AIDS Commission work area. In even the first Trump administration, I was a science envoy for the State Department, traveling around the world, hoping to help countries be better prepared for a future pandemic, which of course then came very shortly after that. And so from that standpoint, I've never been partisan. I'm here just to serve and to try to provide the best information I can. So please take my comments in that light. Now, don't confuse politics and policy because they are very different. And I head up the Center for Infectious Disease Research and Policy. And let me give you the best example of what I can to understand what that means. You could have the very most effective vaccine in the world that's very safe, that is relatively cheap to purchase and administer. But if people refuse to take that vaccine for whatever reason, it's not effective. You might as well not have it at all. And so policy is all about how do we bring together our populations of the world to understand what can we do and what must we do to improve on the health of our population. And in that light, let me just comment on my 50 years in public health and what it means today. Without any doubt, I've never seen a more disruptive and frankly dangerous time in modern public health for the world. We are there today. The events of the last 3 months have been nothing short of devastating in terms of public health. First of all, the opening announcement after this administration came into existence was to join one other country in leaving the World Health Organization, and that in that regard, we were now going to no longer be engaged on an international level. And as Doug just asked earlier, we are a global health community when it comes to infectious diseases. So that we could go into much more, but that's quite dangerous. But what we saw happening in the next few weeks was the dismantling of an infrastructure that in this country has served us very well in terms of helping to deal with global issues. And I'm notably talking about literally the destruction of the USAID Agency for International Development, an organization that accounts for about 1/4 of our global national expenditures every year. This organization has been at the forefront of dealing with problems around the world that are on our doorstep every day and would be busting through the doors, but not for the programs that are being conducted in those countries. Let me just give you an example. We've now had a fairly good review of what's going to happen with the dismantling of USAID as it is. This is an organization, again, that's nonpartisan in the sense that it always has served what I call the soft power of the United States, the public health diplomacy. Rather than going into countries with guns, it goes into countries with the ability to get safe and clean water, to get vaccines, to deal with that. But we now estimate in the next year, I just want to be clear about this is 1 year. We think at this point, the best data says we'll have about an additional 12.5 to 17.9 million cases of malaria, and anywhere from 71,000 to over 166,000 deaths due to malaria that could be prevented if we were there doing our work. A 28 to 32% increase in tuberculosis cases, including multi-drug resistant TB, which has become a terrible challenge of these resistant strains of the tuberculosis bacteria that are very hard to treat. We estimate there'll be about an additional 28,000 cases of emerging infectious diseases like Ebola and Marburg. There'll be an additional 16.8 million pregnant women who will not be reached for saving maternity care. life-saving maternity care. With an additional 11.2 million newborns not seen for critical postnatal care, an additional 14.8 million children not treated for pneumonia and diarrhea, which is one of the leading causes of deaths among children under age 5. And an additional 1 million children will not be treated for severe acute malnutrition, and many of those children dying from starvation. And then finally, an additional 200,000 additional cases of paralytic polio over the next year will occur, and that will occur every year for the next 10 years. Now, just that's the start. Now think about PEPFAR. I had the good fortune to be somewhat associated with the early formation of this. This is the President's Emergency Program for AIDS. And this program was started by George Bush in 2003 and has enjoyed widespread bipartisan support as it has helped serve the world, and particularly low and middle income countries, in dealing with HIV/AIDS. It turned out that in the early 80s, we watched the very worst of HIV spread around the world. And even here in Minneapolis, there were times that I would go up to 5 funerals a week of friends and colleagues dying of HIV/AIDS. And then along came the antiretroviral drugs, these very powerful drugs that initially were thousands of dollars a year for someone to be on these drugs. Today, we can do it for $100 or less for someone for an entire year to be on drugs that can totally suppress their infection, let them live healthy lives, and more importantly, it has the implications for preventing spread, and in particular in the case of pregnant women who are infected. When on drug treatment at the time of delivery and with drugs for the child, in fact, you can prevent the next generation of HIV from occurring, and that's exactly what's happened. We've now gone almost 20 years and have helped create basically an HIV infection-free young children through older teenagers. Now, that program has just been dismantled with over 20 million people now getting their drugs every day, every month, all the time from the PEPFAR program. And in fact, some of the most amazing opportunities, the women of the motorcycle gangs, the individuals who take drugs to these rural villages and are sitting there and do a direct observed therapy as people take their drugs. They have a very efficient means of delivering these drugs, highly accountable. And now we're going to watch literally 20 million plus people with HIV who have now suddenly been pulled off their drugs will die in the next year to 2 to 3 years from HIV. We're going to watch basically a mass death situation occur if we can't find anyone else or any opportunity to get those drugs to these people. Now, you know, you tell me what, it doesn't matter what religion you are. It doesn't matter what your political persuasion is. How can we let this happen? And remember, this is an organization that for all of what it does, it's less than 0.25% of our entire federal budget, a rounding error at the Defense Department. And so when you look at that, you have to realize the challenge that we're going to see globally. Then on top of it, and most people don't understand this, in the United States, state and local health departments are actually really under the primary authority of the state government. And what I mean by that is that when the Constitution was written, anything that wasn't included in the Constitution as an authority was then delegated to what is considered states' rights issues, meaning that we as a state are responsible for our own public health. But over the past 40 to 50 years, the federal government's really taken largely the responsibility for funding state and local public health, such that today, in a state like Minnesota, which has a crown jewel organization for public health, it's been remarkable. About 95% of all the support for infectious disease work in this state is federally supported, 95%. And that's common around the country. Those funds, which come from the Centers for Disease Control and Prevention, are about to be cut drastically. We are going to see state and local health departments that once were very effective, critical assets in our community become basically shadows of what they were. That's going to happen soon. I don't think people understand the dire consequences of infectious diseases on a global basis, including right here in our own backyard. And so this is not a partisan issue. It shouldn't be. This should be an issue about what can we do to protect the public's health. And you know what? we all recognize we're all going to die. There will always be a top 10 causes of death in this world. But I think we all can agree the way we want to die would hopefully be living long, productive years of life, full of joy, full of accomplishment, and then we die at that last minute. To die when you're a young child, to die when you're a young adult from a disease that could easily be prevented by just the kind of very low level investment we're talking about here, the low technology kind of issues, is hard to fathom how anyone can let that happen. But we're about to let that happen. And with the compromise we're now bringing to the World Health Organization by pulling out as we have, not only just our support financially, but also many of the technical experts at the WHO were CDC employees that were deployed to WHO, more than 50 experts at WHO who no longer can work there. And so I can't say this in any stronger terms. We can't accept this. We can't believe that this is a norm. We will look back one day, and I have no doubt about this. If we let this happen, we will be asked by history, how could you have done this? And we've had, unfortunately, other experiences in our history where we've had to ask that question. Why do we have to ask it here? Because this is not about an ideology issue. This is not even about how you're going to save money in your overall global budget. This is a very different issue. So I know this probably is long and protracted, but I want people to get a sense of just how desperate we are right now. And we don't have to be. This is not one where we don't have the technology. It's not that we don't have the resources. It's not that we don't have the support of local governments around the world. It's because we just decided we could.
Thank you very much. Before Doug goes to his next question, I have a bit of a follow-up to that. What do you think is the role of organizations such as faith-based organizations and others to step into this quagmire that has been created here and try and address these issues?
Well, let me just come back to what I just said. Were you not somewhat startled by this kind of approach? Were you not somewhat disheartened by what I just shared with you?
Yes.
How can anyone, I don't care what background you have, I don't care what your belief systems are, how can anyone agree that this is acceptable? And so, yes, do I think that any one of us can change that? No. But when you noted earlier about, standing up and being counted, that's what we've got to do right now. And, again, I work in a world of policy. I try to change things, not in the sense of it's my politics, it's the policy of the world. You can help affect that policy by standing up with your politics. Okay. And I think that is letting those who are your elected officials know what the challenges you see are and how you want that changed. And so I think that it's really important to understand what this means. And again, if this were a matter of imprecise science, if this was a matter of our country at great risk financially of not doing this and therefore needing the resources here in our own country, that would be one thing, but it's not. This is not. This is about a political decision. And so I hope that everyone, without regard to religion, without regard to race, ethnicity, I don't care if where you're at on the financial scale, this ought to be something you ought to be standing up about. And you ought to be letting your elected officials know this is just plain unacceptable.
Thank you.
Thank you. Thank you. It is shocking. The scenario you played out, which is hard to imagine that we could avoid at this time, but maybe there's still hope. I still get emails.
Can I just interrupt, Doug? Because it's really important point. We can avoid this right now. We can. This is not yet done. Now, we have already seen basically the destruction of USAID, and it won't ever come back quickly. But you know what? We could do this. And let me just add one last piece, because this is, again, where I think it's really important. Public health has always been what I call the powerful and gentle power of the world. It is soft power. It is when you take to these many villages around the world, to these cities around the world that don't have clean water, that don't have vaccine programs, that don't have maternal and child health clinics. And we bring these limited resources it takes to make those happen. We buy such goodwill. We buy the intelligence of being in those communities and welcomed in those communities, not as somebody who is seen as an adversary. We are giving that all away to other countries right now that will come in, and countries who I think many in this podcast would probably agree are not the ones that we would want to have in those countries doing what they're doing. And so we are giving away a great deal of the soft diplomacy that has worked so successfully, so cost effectively. And at the same time, oh, by the way, the benefit is we don't have to experience these same illnesses here in the United States because they never enter our borders, because we're controlling them around the world. So I hope when people hear this and understand this is not something that has to be optional. This isn't something that has to be going through certain kinds of changes or more developments before we can implement it. We know how to do this. We know how to do it really well. And we can do it effectively. We can do it cost effectively. So I hope that everyone listening to this understands that this is really, truly a tragedy because it doesn't have to happen.
It's a great point, Dr. Osterholm. And, as we think about this difficult situation that we're in as a country, I know that Doug wants to ask you a question about, where GHM is now and the work that we do. This is a great place where we can really help out right now because of the work that we do in other countries. And so, Doug, I'm going to turn it over to you for your next question.
Yeah, sure. No, we can go there. That's great. I just really appreciate you saying in no uncertain words, this doesn't have to continue. This
Right.
doesn't have to be our future. We can still make a difference. Um, and we partner in small ways, way smaller than the United States government. That is not we can't compare at all. Um, but we partner in 3 continents with low and middle income countries where we support faith-based efforts. And most of what we work with are faith-based efforts in relatively remote places where few other efforts are happening because often the church is there and the church's efforts is making an effort. It includes community health, community health workers, community-based primary health care. Would you be willing to talk a little bit about the role of community health efforts? You've already done it some, but would you be willing to talk about that in low and middle income countries relative to public health globally?
Sure. Well, first of all, let me just add a context to the PEPFAR program. That has been based in large part on the support of the faith community. They have been some of the strongest supporters of making PEPFAR a reality around the world. And as such, they have basically allowed 20 million plus people to live happy, healthy, successful lives and to continue to be productive members of the community. And so, from that perspective, faith based activities have been very important in helping to make that happen. One of the things that we say here in this country, but it's true around the world, all public health is local. It's all local. It's about the conditions in that community, in that area. It's the challenges that maybe differ between different communities. And so you have to know the community. And one of the things that your organization, as well as other faith based organizations, have done, they're in those communities. They're not just in there for a day or two or a week or two or a month or two. They live there. They are part of that community. And that allows them to be very critical advocates for and providers of the kind of global care that we're talking about, global health care. And so I can't say that enough, that that is such an important aspect of what we do. And so the old line, it takes a village to raise a child. Well, there's a lot of truth to that. And this is where local and regional public health around the world collaborating with the willing organizations, the coalition of the willing, including the faith-based organizations, make this possible. It's not done by one person. It's not even done by one group. Now, the USAID provides a tremendous amount of support for these groups. They provide the drugs, they provide the bed nets for the malaria, they provide the kinds of things that will make it possible to have clean and safe water supplies. But in the end, how they get implemented is often local. And so all I can say is to everyone listening to this, I hope you realize that you have organizationally played a very key role in helping to make this happen. We can't let this end now. You know, I worry about organizations like yours who have had the tools in the past, the vaccines and so forth to use, not having them anymore. And so, in a sense, your own effectiveness becomes a greatly reduced issue. And so we have to see this is all about partnership. This is all about who can lead, who can carry things out, who can help assess what we're doing. And, I can't say it in any more strong terms. We need you. And right now, we need you to help us keep this entire system that has been so wonderfully created over the years from being totally destroyed.
Anecdotally, we have emails coming in every day from our partners, and almost every day. And today we had one from Ethiopia talking about they don't name it PEPFAR, they just say American funds for their HIV/AIDS effort, their hospice efforts, their malaria efforts. And they said virtually all of their staff are going completely unfunded, not just the medications and the outreach because of the cuts already. And many have been displaced because of it, because they don't have a way to continue life. And it's small compared to the millions that you gave us in numbers, but it's people we know. It's now, they're talking about 250 to 300 of their patients who are going to be dying in this same period, and their staff being just distraught and unable to do it. We see it over and over again, all over the imprint that we get to walk with, the people. Just want to add that anecdotally. You are really touching a very real reality, and we see it.
So I'd like to follow up, Dr. Osterholm. You had commented earlier when we were talking about the impact that all of these things are making, both in the United States and globally. When we think about the virus trends and everything that is going to be impacted, of course, we had COVID-19. Are there lessons that we learned from the pandemic that may help us through what's coming that you can think of?
Well, let me just start it out by answering it in one broad overview and then come back to it. Yes, no, and maybe. Okay. So, in terms of the yes part, let me just say that there were a number of issues that we could have learned from, and I wish we had, about how to be better prepared for a future pandemic. That's what gets me to the no, maybe. Some of us have urged for at least the last 3 to 4 years that we need to have a really what we call a significant hot wash or a review of what happened with this pandemic. The best example I can give you of how important such a thing can be is after 9/11, there was a 9/11 commission that was formed. It was a bipartisan group, no finger pointing, no blaming, just a very deep dig into what happened. Why did this happen? What can we do differently so it wouldn't happen again? And how would we do that? And it was a very important document, a foundational document in preparedness. Well, if you look at the pandemic, we've not done any of that. And we've urged for that to happen, in a way that is not pointing fingers, is not laying blame. It's saying, okay, this happened. What could we do about this? Or maybe this was the way we wanted it to happen, okay? And there were a number of lessons that we should have learned and could have learned and haven't. I think the one thing that has been by far the most challenging thing for me has been the fact that we really, as a public health community, lost the trust of many, many Americans as to what needed to be done and how it needed to be done. And there were lessons learned that could be learned there that would help us immensely for the future. And again, that's not happening. So at this point, I would say that, that work is still critical. I have a book coming out this summer that is all about that. I've tried to do my very best and honest role as somebody who was at in the front row of what was happening with all of this, and saying this is what we should have learned without blaming, without pointing fingers, but laying out all the challenges that occurred. And so I think from that perspective, if we don't do that, we're going to go into the next pandemic with very little trust by the public. And that's going to create even more challenges for the future. I think the second thing of it is we've not understood that when you have a pandemic, the one true tool you have that is a godsend is effective vaccines. And right now, the only two infectious agents that I think really are at high or increased risk for causing the next pandemic is influenza virus and the coronavirus. But these are what I call virus with wings. They're transmitted by the respiratory route very effectively, often before you're clinically ill, and therefore it can spread quickly before anyone knows it's happening. And we still have what I call good vaccines for these areas, but they're not great. They don't have durable immunity. They're not ones that necessarily are going to be that effective after even a few months. Today, if you are, protected even 40 to 50% of the time against getting infected after 3 or 4 months of being vaccinated, that's still considered good. Now, that's better than nothing, but it's not what we need to be. But the second part of it is we don't have a manufacturing capacity to quickly scale up these vaccines. With influenza today, we can make about enough vaccine to vaccinate 2 billion people in the first 12 to 18 months of a pandemic. Well, think about that. 8 billion people on the face of the earth. The math doesn't look real good that way. Now, we're a little better off with coronavirus vaccines only because we have the mRNA technology. This mRNA technology can be scaled up much quicker. The problem is we have so many people today that won't take it. They don't trust it. They won't take it for COVID, let alone for anything else. And just recently, the Biden administration, before it left office, provided the Moderna company, one of the mRNA vaccine manufacturers, $500 million to research making influenza vaccine with mRNA technology and purchasing a substantial number of doses so that it might be available, hopefully with a match of whatever it becomes from the flu world. Well, that just got clawed back in the Trump administration. So that's no longer happening. So we don't have any more information on this issue of flu vaccine. And just earlier this week, the announcement came out of the NIH that they no longer will fund any work at all on mRNA technology. So, I mean, we're in rough shape. We would not have an adequate supply of vaccines in any timely way at all for a future pandemic. So that, again, is another lesson learned. That would be one that would be very, very wise. And, I think if I could use one last example of why public health is as it is, public health is something that happens every day, but people don't see that. What they see is when the crisis happens. And that is a different kind of public health. And let me give you the example how I think it compares to. Today in the state of Minnesota, one of the most well-funded fire departments with incredible equipment, incredibly trained fire staff is the Minneapolis-St. Paul International Airport Fire Department. The two airplanes that went down in the history of the airport both went down short of the airport in South Minneapolis in the 1950s. Both were handled by the Minneapolis Fire Department. That airport fire department's never handled a large crash of any kind. Now, we pay for that every day because we wouldn't run that airport for 1 second without it. And we saw just a couple of weeks ago in Toronto the benefit of having that, because that rapid response by that fire group is what saved that plane from burning quickly and taking a number of lives with it when those people were able to finally get out of the aircraft. Now, we need to think of public health in the same way. Those vaccines I just talked about are like the fire trucks. You can't go out and buy one the moment a problem happens. You got to have it. You can't go and expect that you're going to have experts there to work that equipment if you don't keep them trained and keep them on staff all the time. And we need to think more and more about that, like that for public health. It's just a price too large to pay if we don't do it. So I think to summarize it, I'm not at all happy to say that we're not as prepared now as we were in 2020. And that's because we've lost the trust of the public. And we are passing up many, many opportunities right now to learn how to do it better. And we're not doing that.
Yeah. Well, thank you for sharing your perspective. I appreciate it. All right. I'm going to turn it back over to Doug.
Thank you. Yeah. I know where our time is limited. I want to just be sure I ask you this, and that is, we're in a time of lots and lots of people getting lots of information through social media, internet, variety of different sources, a lot of misinformation as well as helpful information. And I wonder if you've got any advice for us, really how to recommended sources, maybe in addition to your book, but your book's a good one, but ongoing sources that we could depend on.
Well, at the risk of sounding biased here, I would refer you always to our CIDRAP website. We have a very active news team. We are constantly putting content on, summarizing the state of the art. It's free of charge. There's no paywalls. This is something we're committed to, is making certain that people have access to this kind of information. Um, we actually do it in a way also that we're constantly providing the background information. So, for example, if we do a story on X, the 5 links that relate back to those studies that directly impact X or the new announcement are all there. So you don't have to wonder. You can go look for yourself to see, does that story about the story really make sense? And we think that that's really important. We are very fortunate in that because of our reputation, we're able to get the world's leaders in infectious disease to talk to us and to be part of it. And so, we've tried really hard to do that. I worry a lot right now about the media, news media in general, because so much of it's behind a paywall now. And even to the example of the editorial quality, I think we have to be careful. I jokingly say, but with some real seriousness on the side, that during the pandemic, some of the best articles written about the pandemic were in the New York Times, and some of the worst articles ever written about the pandemic were in the New York Times. Okay, so this is a challenge of trying to vet these so that I might find on a given day that story that I read in the Times was really well done and based on good information. And the next story, well, that lacked a lot. And it was clear that these were people who did not have primary experience in public health or infectious diseases. So I wish I could give you a kind of a outline of, you read this, read that, read that. I can't. I think right now all I can say is I can surely account for our CIDRAP information. And again, I would invite people to come and review it. Again, there's no financial issues with us on it, so they can trust it at least from that perspective. And hopefully you can tell I tend to run an organization that is about speaking its mind, speaking up and speaking out, and taking potentially positions that might not be popular, but they're the ones that are based on the science.
And how do they find that information, Dr. Osterholm?
You can go to our website. It's www.cidrap, CIDRAP .umn.edu. So CIDRAP, Center for Infectious Disease Research and Policy. So www.cidrap.umn.edu. And one of the things we do, for example, is I do a podcast every 2 weeks. That people can get the latest information on what's happening. But our news team, as I said, is active, very active. Every day we're publishing an entire set of articles about what's happening in that day or issues of great importance. We put a lot of other content. We're the group right now from a global standpoint that's overseeing what we call roadmaps for better influenza and coronavirus vaccines. We've brought together the leading experts in the world for both of those vaccines and have laid out a roadmap to say, what are the next steps we need to do? How do we get from A to B, B to C, C to D? And that's all on the website too. So all that information is available free of charge.
It's a great website, and your podcasts are wonderful to listen to.
Thank you.
Incredible resource that you can help us with. Thank you. I'm so
Thanks.
grateful. that is something that we want to be continuing to lift up, even as we try to double our efforts at Global Health Ministries, but also just speak publicly and try to help make a difference in terms of changing some of
Well,
the
as
future.
we come to an
So,
end here, I just want to say to all of your listeners, please stay engaged. We need you. This is now about the coalition of the willing. We got to speak up and speak out. The kinds of things we talked about tonight, we can't rest knowing that this is happening. And if there was ever a commitment to faith, without regard to which faith it is, if there was ever a commitment, now should be the time that people are coming forward and saying this is not acceptable to their legislators, to their, whoever is in a policy position. And this is going to be at the local level. I just got done giving an example of what's happening in Minnesota. Our own state legislature, are they going to help us with this issue if all the federal funds dry up? And again, this is one of those ones. There was an old commercial many years ago when I was a young kid, the oil fram commercial. And the old line used to be, you can pay me now or you'll pay me later. And I can tell you, if we have to pay later, it'll be a much, much higher cost. And as a result of a lot of suffering and death.
so well said. Thank you. Thank you. Oh, God bless you. It's been an incredible privilege to hear the data, the passion, and the wise counsel. Thank you.
Well, and the other thing I would also leave us with, we're all in this together. Okay. So I look forward to being there with you. And I hope that you'll find having us there with you is also helpful.
Amen. It is a help. You're a huge help. You're a huge resource. Thank you. God bless
Thank you very much.